has a question? No questions? We've taught you so much this weekend, there's nothing else to learn. Okay, you're closest, so you're going first.
I have a general question. If we're wanting to compare different diagnostic criteria as a layperson and a patient, is there a resource that we can go to look for medical diagnostic criteria that our doctors would be using that we could have access to?
In 2015, the Heart Rhythm Society, in conjunction with the American College of Cardiology and the American Heart Association, published a consensus statement with a series of diagnostic criteria for vasovagal syncope, postural tachycardia syndrome, inappropriate sinus tachycardia syndrome, which was also signed on by the European Cardiovascular Society and the American Autonomic Society. And that was published simultaneously, principally in the journal Heart Rhythm, which is the major electrophysiology journal. I believe it was also simultaneously published in the Circulation and the Journal of the American College of Cardiology. There also was, again, a joint committee of the American College of Cardiology, American Heart Association, Heart Rhythm Society, and European Cardiovascular Society published guidelines for the workup and definition of syncope, which was published simultaneously in Heart Rhythm, Circulation, and in the Journal of the American College of Cardiology. All those are open access so that you can get to them. I was the co-chair of the Heart Rhythm Society when the consensus document. So they were an attempt to make a uniform set of criteria. But as I have said before, Stephen Hawking famously said the universe is analog, not digital. That these are arbitrary, somewhat guidelines, where you have to choose a number and say, this is the number we're going to use, and you've got 12 people arguing with each other in a room over a six-pack of beer about what the number should be, and all have great evidence and data suggesting that their opinion is correct. And you end up making a political compromise, where you say, okay, will you accept this one and will you accept that? And you come up with a number, but that, again, you have to realize that these are somewhat arbitrary things. We have to have some kind of criteria. We have to have some point where we say that you've crossed a certain line between normal and abnormal, but there are all kind of variances there. So that's the one caution.
Okay, Mr. Moore is going to help us take the next question. He's over. Stand up, or I don't know where he went. Okay, well, I'll take the next question. Somebody over here. Okay, here you go.
Hi, I have a question about the correlation between Chiari malformation and POTS. Are you seeing a lot of similar symptoms? I mean, I've seen it in my kid, but are there any studies that correlate the precedence and the prevalence of those symptoms, and are they treated differently?
If you walk into your doctor complaining of chronic cough, it could be to an allergy, a cold, a postnasal drip, emphysema, or lung cancer. And they would all have the same cough. And so disruptions in autonomic control can occur from a variety of different things. One of them can be things like Chiari malformations, where particularly in people, it seems to be higher in people with hypermobility syndrome. The brain sort of sags down and pushes through the foramen magnum. And they can get a lot of other symptoms such as headache, neurologic abnormalities. I think the one caution is there was a time where we thought that fixing the Chiari malformation would fix their autonomic problems, but that doesn't seem to be the case. And indeed, the American Academy of Neurosurgery now recommends against doing Chiari things to fix autonomic problems. Now, if you have severe intractable headaches and muscle paralysis, that's a far different thing. So just like we said that trauma can wreck part of the autonomic system and cause problems, strokes can cause it, autoimmunity can cause it. I mean, a whole bunch of different things can cause it. I see a lot of patients, since we have a big cancer center, where chemotherapy has wrecked their autonomic system. So again, you're talking about a system. It's like saying, the comparison I use in cardiology is congestive heart failure, where there's 100 different things that can damage heart function and put you in the same place, but for a very different reason. So that is one of the reasons.
Just wanted to, this one's not on? It's on now. I just wanted to mention that Dr. Glenn Cook just joined us up on stage. Somebody over here have a question? I was going to go to her first.
What do we know about the relationship between migraine and POTS other than the fact that they tend to co-occur?
Professor Hughes and, Dr. Cook too, but I think Professor
I'm
Hughes
not sure.
probably
Am
has
I
an
on?
answer.
Okay. I would say very little. We know that individuals with POTS have higher rates of migraine than the background population. So, women have migraines more often than men. Women have POTS more often than men. But even accounting for that, the rate of migraine is higher in individuals with POTS. Yeah, I think we have a few theories of why that could be. One thing to be aware of is the risk of secondary headaches, that it's not strict migraine, not a primary headache disorder, but a headache due to something like spontaneous CSF leak, and that's something that we've talked about here at the conference. So being aware of the risk of other secondary headache syndromes. But even then, just the risk of migraine itself, we know that it's a neurovascular disorder. Is there something different about some people with POTS that relates to their vascular structures and creates their orthostatic intolerance that may also contribute to migraine? Sure, there's a chance. Is there something involved with central sensitization that increases the risk of orthostatic tolerance and increases the risk of migraine? Absolutely, there could be something like that. And it probably varies from individual to individual. I think one of the other questions, what do we know about people with POTS and migraine? We'd ask, do people with migraine who also have POTS respond differently to medications for migraine? And the answer is we don't have any data in that regards in terms of outcomes, responses, in terms of having an improvement of headache. We do know that a lot of the medicines that we use for migraine have side effects that may be worse in someone with POTS or dysautonomia in general. And so being aware of the side effects of medications and how those might worsen the symptoms of POTS or might actually benefit some of the other symptoms of POTS or accompanying symptoms, being aware of those and choosing medicines judiciously is important.
I was going to ask Professor Hughes to kind of give us, on the migraine question, you had talked about this pretty extensively during your lecture.
Thank you. To me, it's a very big, I very much agree with your last comment. This morning I had to talk about the antiphospholipid syndrome and the growing awareness that there is a big overlap. We don't know how big. I must confess, even in our unit where we see 400 patients a month, we had not realized the significance of the extent of the overlap with POTS, and we are now beginning to realize it, and certainly it's been an eye-opener for me today. I would say next to memory loss, migraine is the commonest feature of Hughes syndrome, the antiphospholipid syndrome. Not only that, but we run a weekly lupus pregnancy clinic, mainly for patients with antiphospholipid syndrome, and the day you start the heparin for their recurrent pregnancy problems, the migraine stops. They go for 9 months through a pregnancy without a headache. So it does look to us as if in the subset with antiphospholipid features, it's a sticky blood phenomenon or maybe a vascular flow phenomenon rather than a vasculitis or anything direct. And your question of maybe it's a subset of POTS patients that we should be re-looking at, those with migraine, in case there's something like clopidogrel which would stop it.
In your opinion, for someone who's been recently diagnosed with POTS, do you always recommend going deeper, looking for an underlying cause, looking for comorbidities, or would you leave it at that unless there's big obvious things? Thank you.
Yeah. So the question is, if we look for comorbidities in somebody who's diagnosed with POTS recently, is that the question? Do I understand it correctly? Okay. See, again, we have to remember any time we make the diagnosis of POTS, that these sets of symptoms could represent an underlying condition. Not every patient with POTS or two patients with POTS are the same. There could be a heterogeneous condition with several underlying conditions. So I think that time spent will be well spent in the first encounter with the patient to try to see, number one, does this represent POTS physiology, and what could be underlying this? The risk of labeling patients with POTS without in-depth trying to spend the time and to try to in-depth understand what's going on, you'll end missing lots of conditions, including antiphospholipid syndrome or other conditions, because there are, if you look, you will find something. And if you don't look, you will never know what you don't see. You don't know what you don't know. So yes, to answer your question, we do complete review of the systems. For every people differ, but I'm from the philosophy that I will not leave any stone unturned. I will do good review of systems, and if there is, and that's my clue. Let us say you have, persistent abdominal pains with that. Let us say you have some, with those symptoms, you have some hives, you have something, skin lesion or so on. That could lead to what could be an underlying condition. Just simply seeing a patient, and so your heart rate goes up more than 30 to 40. I mean, it's not that simple, I would say, and we should be looking for underlying conditions.
I have a concern that we have very few autonomic doctors in the field. And I've already threatened Dr. Abdallah that he's not allowed to retire. And we don't want to burn them out. And you all are incredibly busy and very hard to get into. And I'm just wondering, what can we do to encourage, if we can do anything to encourage more doctors to go in the field, or, what I told Dr. Abdallah, you need an intern to follow you around all day long and learn everything that you do, because I worry about that. So can we address that?
I worry about that too, actually a lot. And I can tell you that all of us that are here on the stage, all of us that are speaking here, feel that concern and recognize that. And and you're talking to people actually who are you guys are actually part of that solution. Dysautonomia International has done and continues to do a lot in the things that we need to do to improve the care of people with dysautonomia generally. And there's kind of a threefold mission that needs to be carried out. One is further education of general practitioners. So the general practitioners need to really be able to recognize that, hey, there's something going on with the autonomic nervous system. Here are my next steps. Like, hey, that flag just needs to at least catch their attention. The second tier to that is education of medical professionals that really are going to see more presentations of autonomic disorders in their clinics. And so, just for example, especially the neurologists, cardiologists, and gastroenterologists, so that those specialists are able to recognize and manage common autonomic disorders. And then the third thing is getting people actually to become autonomic disorder specialists. And how do you do that? And so how do you get someone to go into a fellowship in autonomic disorders? You all can push for that. There are a handful of autonomic disorders fellowships programs throughout the country. There are opportunities for physicians to do mini fellowships. So I did my training at the National Institutes of Health, and the clinical neurocardiology section there actually has a mini fellowship that people can come do. And I'm kind of biased because I actually wrote the training protocol that they see patients under. And there are other ways that I'm getting actually more involved with that. So education of general practitioners, education of specialists who often see people with autonomic disorders, and then helping get really the physicians coming out of their training into that subspecialty autonomic disorders track. All three of those need to be targets for things that we do as a field. And I see you all in this room and Dysautonomia International as an organization as part of moving those things forward, because you actually have a lot of influence both locally and nationally. So keep talking about this and keep asking that question. We appreciate you asking that question.
I actually just want to add to Dr. Cook's statement about what, as an organization, we're trying to do and how you can be involved. We've actually been asked to fund some additional autonomic fellowships at some of the major autonomic centers. And it's something we would love to do, but it's about $100,000 a year, and most fellowships are 2 to 3 years. So get involved with fundraising, and every dollar we raise, whether it's $5 donation or a $50,000 donation, we put it to good use. And part of our mission is training more doctors, not just in continuing medical education courses, but actually creating fellowships. So something we'd love to do. It's just a matter of raising the money. And there's a question over here. I still need this mic.
Thank you. My question relates to, are you aware of any research that's been done regarding sleep and dysautonomia?
Lack of sleep messes everything up, and prolonged lack of sleep and I have this. Prolonged lack of sleep, it causes all kind of problems. A study done at the Cleveland Clinic took young, healthy volunteers and deprived them of a large amount of sleep. They slept like only 4 or so hours for 2 weeks, and at the end of 2 weeks, they had all developed a fibromyalgia-like syndrome that occurred. And so I think there's several things that happen. I mean, if you think about what we think the pathophysiology is, that you're upright all the time, you've got all this blood pooling in the lower part of you, your brain's not quite getting enough oxygen, you feel kind of like brain fog and out of it half the day, and then you lay down at night and all that blood floods back to your brain and you go, okay, we're back. And people will say, I hear this all the time, they say, I feel like I wake up when I lie down. And so they can't get to sleep. And they frequently are up very, very late at night and then can't get to sleep, and then don't get frequently good quality sleep. And again, everything is connected to everything else. And you start messing with the system, and you can take what is a relatively smaller problem and make it into a much larger problem. I don't think anyone's looked in a very systematic way about sleep disturbances and its relationship to autonomic problems. But I can tell you just from my own clinical observations that they play a major role. And when you can get people to have decent sleep, it makes them much, much better.
I just wanted to add to that there is a study recruiting here this weekend. Vanderbilt has a table outside, and they're recruiting for a POTS sleep study, Dr. Walters from their sleep clinic. So if you haven't checked it out, they're still recruiting. It's just a survey. It's pretty easy to enroll.
Lauren, Dysautonomia International hosted a webinar about a month ago with the Stanford group on sleep. Is that available online for those that weren't signed up? It's open, so. Vimeo.com/dysautonomia. So just last month, again, a webinar on sleep related to dysautonomia that you can tune into.
I think it's also well recognized that people who have an imbalance of the autonomic nervous system with sympathetic overload and depression of the parasympathetic nervous system aren't going to get good sleep, because you really need that parasympathetic input to get into the good, deep, restorative stages of sleep. So obviously, I'm just reiterating what Dr. Grove said, that there's a very close relationship between the autonomic nervous system and how well you get your rest.
Just one thing. So, Dr. Grubb, you mentioned, I inferred from what you mentioned that it may be possible to treat that with some kind of medication or something. But maybe I misunderstood. So
I mean, you can use meds to help people in various settings to try to sleep. And certain meds can only be prescribed by sleep medicine people. Drug Xyrem and things can only be used by sleep medicine people. So sometimes you have to bring them on board in doing it. Sometimes you can do something simple. Drugs like some of the tricyclic antidepressants, which are very good for treating pain and also treating mast cell problems, are also used as sleeping aids. So you can combine things to try to help people sleep better.
I want your take on compression stockings. How necessary are they to, wear all the time, and if they're necessary at all?
It's hard. NASA has when the astronauts come back from prolonged space time, they can't stand. They lose their muscle mass very quickly, even though they try to work out it in space as best you can. And NASA has made these super compression suits that are like 60 millimeters of mercury pressure. They also cost about 10 grand. And one of my patients from Canada, who probably will win the next Nobel Prize in Physics, I don't know if you know what CERN is. It's the atom smasher, Large Halcyon Collider in Switzerland. And they do all these experiments on the fundamental particles of matter. And if you're a physicist and in your career, you get one experiment run there, that's a big deal. And she's not 30 yet, and she's had 2 run there. And for the University of Toronto to get her there, they actually bought one of these suits for her to wear on the long flights because one of the Canadian astronauts happened to be there and told them about it. So the compression socks are okay, but to really work, they would have to be at such a high level that most of us wouldn't tolerate wearing them. Except if you get these special, like NASA-made ones, which also are mobile. You can walk around in them, but they have to be custom made per person. So, yeah, they can help a little bit, and some people find they're very helpful. But at the same time, it's really hard to get enough compression to really, really work.
Can I add to that? In our particular subject, the antiphospholipid syndrome, it's called sticky blood, and possibly the main problem is perfusion of oxygen to the brain, and the brain is sensitive. And the 3 commonest things we see are memory loss, temporal lobe epilepsy, bizarre but a very frequent feature, and sleep disturbance. And we've done a study, just the same as you mentioned, that showing that sleep disturbance. And one little example is, having just flown over from England, most of our patients with antiphospholipid syndrome have terrible problems with jet lag. We presume from talking to captains of flying and so on that the pressure in cabins is marginally lower than they even admit in long-haul flights. And they do suffer for 2 to 3 days afterwards. And that's a study that's at last going underway.
The further you're flying, the higher they put you. Yeah. One, to get you out of everybody else's way, and secondly, because there's less air resistance, and so your fuel will go further. Yeah. And as planes have gotten better and better pressurized, there's less of that. Yeah. But still, they're flying further and further.
Yes, I have a question about functional neurology. What are your opinions on functional neurologists and their attempts to retrain the brain? Do you think that is beneficial?
I can't answer the question.
I'm a neurologist, I can take this one. So the question on functional neurologic disorders. So functional neurologic disorder is the term that we more commonly use now for psychogenic disorder. And so what does that mean? So a psychogenic disorder means coming from those voluntary areas of the brain, even though it's not voluntary. We could spend the next hour talking about this, right? Don't worry, we're not going to do that. So functional neurologic disorders, psychogenic disorders, somatoform disorders are really common and actually are really normal. Lots of people, when they get up to talk in front of a crowd, start to get sweaty palms, start to get abnormalities down here in their tummy. Is that because they have a pseudomotor problem or some gastrointestinal problem? No, it's normal. It's normal to manifest stress with physical symptoms. That's number one. We all do it. There's a spectrum of normal, though. And the interesting thing about functional neurologic disorders or psychogenic disorders is that it's on one end of the spectrum to where it becomes abnormal. It becomes pathologic. Even that, though, is really common. And we know across the literature in specialty clinics, functional disorders, psychogenic disorders are common. And it's important to recognize that functional or psychogenic disorders, the diagnosis is not made by the absence of an explanation for a problem. So it's not, I don't know what's wrong with you, therefore it's functional, right? That's called a cop-out. That's not a diagnosis, right? And I think that's why some people have had bad experiences with healthcare providers using the functional neurologic disorder diagnosis as a cop-out. And some of you in this room have probably experienced that, right? However, what we often use are positive findings, where we see things physically, where it's clear that this is coming from a voluntary area of the brain. And then it's not an absence of information, therefore we conclude it's functional. No, there are findings that tell us that this is a functional neurologic disorder, positive findings. And oftentimes we'll even confirm that with actual physiologic testing that will confirm that the disorder is functional or psychogenic in nature. That doesn't mean that there's not something else going on at the same time, right? So again, functional neurologic disorders are common. People can be sick from a lot of other things. Also, when the body's sick, it may make the mind more likely to have a functional neurologic disorder. And we could talk about theories why. I won't bore you at length with my thoughts in that regards. So it is important that they be recognized. It's important that they be talked about openly, and it's, I think, important that that the positive findings, that is, the things that tell us that it's coming from those voluntary areas of the brain, be highlighted and talked about. You have more?
Yeah, if I might just add, there's a field called functional neurology, which the people are trained in this area of functional neurology, which it's unfortunate because the words are the same, but they have a completely different meaning. And I'm familiar with this only because there's a chiropractor who is a functional neurologist who works up in Lancaster, Pennsylvania, to whom I've been referring quite a few of my patients. And he has a completely different approach to the management of, for example, the dysautonomias, dystonias. I've had several patients with dystonias whom he has a set of exercises that he works them through, including eye movements and things like that, that have enabled people to get back to a more functional state than any other more conventionally trained practitioner to whom they've gone. So I think there's a lot to be learned from what those people do, and I for one, would like to learn a lot more about it myself.
And to pick up on what Dr. Francomano said, you asked a question, this idea of retraining our brain. And our brains are actually retraining themselves all the time. Like our brains are very plastic, and we're constantly retraining our brains from a motor standpoint, from a cognitive standpoint. We are always retraining our brains.
Okay, so Dr. Hughes said about temporal lobe epilepsy. So I wanted to see if you have ever had any cases where there's dysautonomic epilepsy, where the seizures are causing autonomic symptoms.
Can you repeat the last bit?
Yeah, where seizures are causing autonomic symptoms.
I can't answer that specifically. I just quoted this morning the latest data, which is very exciting, that, if you're 11 times more likely to suffer seizures if you have antibodies to phospholipids. And this big study from Israel and Italy have shown that teenage epilepsy, 1 in 5, is a feature. And one of my patients recently she got quite severe Hughes syndrome and temporal lobe epilepsy. And interestingly, she was an EEG technician. And she said when she was training, she tested 4 of her siblings, and they all had temporal lobe patterns on EEG and migraine. So it's a very nice question, but I've not noticed particularly autonomic attacks, if you like, at the same time as temporal seizures, but maybe we haven't been looking.
So again, the neurologist on stage, we see lots of people with epilepsy, really common, and autonomic manifestations of epilepsy are common. If like that's any second-year neurology resident had better be asking questions about autonomic symptoms in someone for whom there's a concern for seizures or epilepsy. The thing to be aware of is that one, seizures are episodic. So they happen, they go away. And second, they're stereotyped. So the same thing happens. Or someone might have a couple, 3 different types of seizures, but they're stereotyped. And so the same thing happens time after time. So if someone has a stereotyped spell, that's when we really get concerned for epilepsy or seizures. But yes, autonomic symptoms are very common in seizures, and that has to do with where they most commonly arise in the brain.
Several doctors this weekend talked about IVIG as a treatment for autoimmune-related diseases and disorders. Can you address any risks that you've seen with using IVIG, and is it considered an experimental treatment or not?
So my own opinion on this is I come from a generation that gave thousands of people hepatitis C and AIDS before we knew those diseases even existed. I was in Baltimore when the first AIDS patients arrived in like 1981. Prior to that, they had gotten, the science fiction writer Isaac Asimov got AIDS from getting a blood transfusion during an open heart surgery. Arthur Ashe, the tennis player, the same way. And so when you receive IVIG, I think there's like 90 donors per dose or something like that, or perhaps more. And you can test for what you know, but you can't test for what you don't know. And it turns out there's not only a hepatitis A, B, and C, but now there's an E, F, G, H, I that we might be transmitting to people for all I know. And so the one concern I have, having lived through that era, is that yes, we screen all these very, very carefully for the things we know about, but how many things don't we know about that are out there? And again, I watched many, many people who had initially in the early time of AIDS had gotten it through blood transfusions, through things for hemophilia, for all kind of things, inadvertently. So there's always that kind of worry. And the other thing is there are a tremendous number of minor incompatibility groups that occur in blood. There's dozens. You check for the certain major ones, but there's tons of these other ones. And when they batch all this stuff together, you're getting exposed to all kind of incompatibility groups, so that as time goes on and you get it, you can get almost like these serum sickness reactions that when you get the dosing. And so it's not to say you shouldn't do it, but there's nothing that's risk-free. Or being back in the South now, to shift back to my Southern origins, you never get something for nothing. That whenever you entertain any kind of therapeutic approach, you are taking a risk. And that's okay as long as physician and patient are aware of that risk and are looking for it. And the other thing is trying to get it approved is a nightmare.
Can I add to that? We've used it over the years like everyone else in our lupus clinics. It's a black magic. We don't know how it works. It's a big mixture of other people's antibodies, and maybe it works that way, maybe it doesn't. But we used to use it always on Friday night lupus. Is very sick with fever, where you really didn't want to give immunosuppressives, but you could give IVIG safely. But there are the problems that you've mentioned, which haven't been overcome. And one of the silly things about it is that we still give 5 buckets a week of this like milk urns full of IVIG. And it's amazing to me that the scientists involved haven't reduced it down to the particular antibodies that you may think are doing the damage. So I see a future for it, but clean antibodies, not just a milk bucket full of antibodies that we're currently giving.
Okay. There are also some patients, who take it where, they carry diagnosis of immune-mediated, and they take like 6 or 7 of these infusions, and there is no benefit, okay? But in the meantime, these patients have been, exposed to blood products with some of the consequences that we don't know. So I really, now there is a trend to overdiagnose conditions as being autoimmune and to prescribe IVIG. I think we need just to be careful, because also the more we use it, the more we're going to see problems.
I'm just going to add a little something to that. I think most people heard our announcement that we're doing the first IVIG clinical trial in POTS, but that doesn't mean everybody should go out and try to get it. It's not like taking a Tylenol. It's a pretty serious drug. So I know it's hard to wait, but Dr. Vernino at UT Southwestern is going to lead a study. We're going to try to figure out what patients it might help, what are the side effects, what are the risks we have to look out for. So eventually that will be published, and we'll have a little bit better guidance on what types of patients might benefit from it.
I would like some practical advice. If you're on the front end of this journey and you've just recently gotten a diagnosis of POTS, and you're trying to kind of get your landscape of what exactly you're dealing with, do you think it's better to try to approach one of these centers that specializes in dysautonomia and try to get like some grand workup where they're looking at all your systems and giving you like baseline assessments, or just do the best you can with the doctors in your metropolitan area and try to like make your own priority list and chase what you think your biggest problems are?
I think it depends on how sick you are and how well you're doing. Oftentimes, there are unfortunately only 7 days a week and 24 hours in a day. And so most of us are extremely busy and work incredible hours. I think my girlfriend has told me she wants me to cut back to working half a day. She wants me to start work by 8 and then come home at least by 8. So I have the rest of the other half of the day I can have to myself. But because of the delay factor in getting to people, one, just be sure your diagnosis is correct, and secondly, hopefully people can learn. We've published tons of information about how to approach managing people, and this is usually easily available in today's world through the web and through electronic media and things, that there are very clear guidelines as to how to start and how to treat people. And oftentimes, as I said, these particular drugs that we use in the initial treatment of individuals are reasonably safe drugs that don't really have major side effects. They're not like IVIG and they're not like the immunosuppressives. And so I think practically I would start out locally and see how you do. And if you're doing good, then fine, you don't need to go somewhere else. If you're not doing well, you should. And sometimes you'll go somewhere else just for sort of overall confirmation and guidance, but then, somebody else, we see 2,000 people a year. I can't directly manage 2,000 people a year. Just isn't going to happen. You give instructions and the local person has to be some kind of quarterback into initiating and monitoring therapy, which is how the ideal should be. Now, having said that, the last time I checked, the world is not quite ideal. But that would be a way I would approach it.
Hi. If someone with POTS is about to have surgery, is there a precaution that should be taken prior to the surgery, or should the surgeon do something prior to?
We usually tank people up. So since you're fasting before surgery, and since people are very sensitive to dehydration, we will usually, before doing anything, give them at least 1 liter of saline before they're going to be put under, because various anesthetic agents can drop your pressure quite dramatically. And it's usually nice to have be seen by anesthesia ahead of time, although I have a lot of issues with the anesthesia people, usually because the person who sees you in their clinic is never the person who actually puts you to sleep. And no matter what the other person said, the one that's going to do it won't believe or do anything you want. But you can choose various agents for anesthesia based upon problems that people have. But hydration is one of the major ones I've seen have gotten people through things. Hydration both preoperatively and intraoperatively, because as I said, the anesthetic agents often have vasodilatory effects to them and will lower your pressure during surgery. So keeping someone reasonably well hydrated during that whole process seems to have eliminated most of the problems. So before colonoscopies or endoscopies, for example, they're going to put an IV in you anyway. You know, you just show up, we tell them, just let them show up a little bit early, run a liter of fluid in, or at least half a liter of fluid in. That way they won't crash when you give them anesthetics. Or with dental surgery, we've said the same thing. Oftentimes, if they're going to use, and they frequently use Versed or they use midazolam or they use fentanyl or something like that. We give them at least a liter or so of saline ahead of time, and they do much, much better. And we also tell them for like outpatient procedures such as colonoscopies and things like that, to have the reversal agents immediately available if somebody really bottoms out on them. So there's a drug called Romazicon that can immediately reverse the effects of Versed. Narcan can immediately reverse the effects of fentanyl and things like that. And those should be easily available to you if somebody really has problems.
Can I say, dehydration seems to have come back to haunt me because when I was young and beautiful, I used to do a general practice locum for a month every year in a village in Kent. And the village GP was slightly eccentric, and every year he had a cure for the village. And one year it was orange juice, another it was dehydration, and all the schoolmistresses had to have jugs of water in the playground. And it was this same doctor who taught me dermatology. A patient came in with a rash. And I asked him what he thought it was, and he said, well, it's either NM or SDSD. So I sort of fell for it, and I said, what's that? Well, he said, NM is nothing much, and SDSD is some dreadful skin disease.
My question is about anesthesia. I know for me, and I've also spoken to other people who have had trouble in the past with it, especially local. What do you do if you need to have a minor procedure and local anesthesia does not work?
The in the people with Ehlers-Danlos syndrome, at least my observation has been that regular lidocaine doesn't work well. But there are derivatives that do, and one of which is called Marcaine. Marcaine is about 3 times more expensive. So usually you don't keep it in the Pyxis and you have to pre-order it and argue with the pharmacy about why you should have it. But it seems to provide better local anesthesia than other agents do. But I've commonly observed that they don't get a lot of they don't get good local anesthesia from it.
Is there a way to test for it? I mean, I know I've had a genetic test, and I know others who have had one that told me, like you said, that lidocaine doesn't work. Would there be a way to pre-test that to know if it would work or not?
Don't know. I do not know.
Okay, thank you.
There are frequently times if I'm going to operate on somebody who I know is not going to get good local anesthesia, and I don't think I can provide sufficient conscious sedation. You know, I'll have them seen ahead of time by anesthesia, and then just put them deeply to sleep, usually with propofol or something. So the local thing becomes irrelevant, you know, because you're just so deep asleep it doesn't matter anymore. But I don't normally do that. I usually will try to use, in EDS people, I'll just pre-order Marcaine and have the pharmacy scream at me for 10 minutes.
There's a comorbidity coalition that Dysautonomia International is participating in, the Ehlers-Danlos Society, Chiari and Syringomyelia Foundation, the Mastocytosis Society, and we have been developing a combined research agenda over the last year, and over the course of the year, we came up with 3 research questions that were very important to all those participating partners. And this question about local anesthesia is one of those 3 questions. So it's a very, very common experience among people who have Ehlers-Danlos and these various comorbidities. And we really don't understand very much about it. We don't understand why people have so much trouble with local anesthesia. And as Dr. Grubb said, some people do better with the Marcaine, but it's not a universal experience. So there's a lot that we need to know about it, and we're in the process now of putting together a study to try to understand that better.
I'm curious about your thoughts on cannabis-based medications for constant nausea. Is there science behind it? What are the long-term side effects of it? Does it really work? Is it worth the risk?
Nobody knows. I mean, one of the problems with, obviously, cannabis seems to work for nausea, and especially for things like chemotherapy-induced nausea, but chronic cannabis use can actually cause nausea. There's a thing called cannabis hyperemesis syndrome, where chronic heavy use can actually cause nausea. But one of the problems with all the stuff with cannabis is there's virtually no good research. And in part, that was because of the fact it was near impossible for anybody to legally get cannabis to research with in any kind of fashion. There was no funding for it. So it really just doesn't exist. And that's one of the problems, is it's just plain, you're going by the seat of your pants. Having said that, especially for the CBT oils and things like that, they do seem to help some people. And I think it's a drug like any other. I mean, it's a drug like any other drug. Now, certain things have been shown to exist. So, for example, they extract a compound within the cannabinoid extract, and it's marinol, is the drug, dronabinol or marinol, which is sold as a pharmaceutical. So obviously, and that had to go through the FDA and approval process. And so obviously there are components within there, because there are multiple different drugs within that plant, that do provide a therapeutic effect. But I don't think I don't think anybody has any good studies about that. And that's one of the really big problems about prescribing it or using it or doing all that.
And you see, we see now the more people are using marijuana, you start to see more increased incidence of psychosis. Because there's some part of the population, they could have a mutation for the gene that metabolizes dopamine in the brain to norepinephrine. And there is an enzyme called N-methyltransferase. If it happens, if marijuana, it also blocks that enzyme, and you could also have more psychotic symptoms. So psychosis among teens who take marijuana is one risk, and it's important. The other issue, when you address nausea, also you address it with you wanted to use marijuana, it's another symptom, what could be causing it. So this is also one of the difficult symptoms we deal with. It's really, I tell patients, really sometimes I feel for you, just, but you could still look for underlying conditions. One of the underlying conditions is MALS, the median arcuate ligament syndrome. So some patients with refractory nausea have been found to have median arcuate ligament syndrome, and they got some relief of their symptoms. The other condition, which is not very rare now, is patients who have mast cell activation. Some of these patients could also have nausea because of that. So I think before we go to that, we should invest the time. Other conditions, CNS, so anything that increases the benign intracranial, what they call it benign, increased intracranial pressure could also be causing nausea. So I would really invest much more, in trying to find what's causing it before I embark on a therapy, whether risky like marijuana or not risky.
I think you'll start to see research come out now that you can obtain it more easily. And I think that there was actually a whole issue, I remember the cover of one issue of Time magazine was about medical uses of marijuana and just how little we know and how surprising that is given how long it's been around. But other compounds, we know that opiates, we've used opiates for centuries, for millennia, to treat pain and things like that. I'm sure they'll have their place, but at the moment, there's just not good research to tell you what that place is.
Yeah. Do you see any major breakthroughs in POTS treatments over the next 5 years? And if so, what might they be?
If the autoimmune data continues to show what it shows, and we can confirm that a particular patient has known autoantibodies that cause these problems, it would open up the possibility of using not just IVIG, but other immunosuppressive agents. And so the approach would then be similar to what you see in rheumatology, in using drugs like Plaquenil, methotrexate, et cetera. But this, at the same time, I mean, as I mentioned in the plenary lecture, these are drugs with really serious side effects. Plaquenil can cause blindness, methotrexate, these suppress your immune system. They give you a chemically induced form of AIDS. And I guess I'm overly sensitive to it because in one of my multiple former lives, I was involved in the heart transplant program. And you may not know this, but rejection of a heart almost never occurs anymore. We stopped doing biopsies on a regular basis because it just never happens, because we have such good drugs to prevent rejection. And what kills you are those good drugs to prevent rejection, because they cause lymphomas, I mean, they cause cancer. They literally give you a chemically induced form of AIDS. We see our transplant patients get the same opportunistic infections that AIDS patients used to get. They get cryptosporidium, they get listeria of the brain, they get all these kind of things because we are purposely suppressing their immune system. So that will be the next frontier, but we will have to approach it with extreme caution because all the things we've used up to this point have very minor side effects, almost no serious side effects. You cross into that world, you're talking a whole different ballgame, where you're talking very serious side effects. But that will be where the future, I have no question that's where we're going.
So it's almost 4 o'clock, so we're going to have to wrap up. I just wanted to take the time to thank our panelists and really all of the experts who come here. They take time away from their busy clinics and their families to join us for the weekend, and they don't get paid to be here. They do it voluntarily. So please give them all a big round of applause.